Today we will talk about hypertension in elderly patients. Age-related changes in blood pressure. Systolic blood pressure rises linearly with age between 4th and 9th decades. Diastolic blood pressure tends to plateau before age of 60 and drops after 60. Prevalence. Hypertension is more prevalent in elderly. In Egypt, 2 out of 3 elderly have hypertension. National Hypertension Project. Characteristics of hypertension in the elderly: pseudohypertension, variability of blood pressure, auscultatory gap. Pseudohypertension, due to increased stiffness of the large arteries, suspected if there is absent target organ damage, arterial wall is felt, resistant to treatment, symptoms of hypotension. Variability of blood pressure, postprandial hypotension as blood goes to stomach, postural hypotension, white coat hypertension due to impaired baroreceptor function, reduced blood volume, diminished beta receptors responsiveness. Auscultatory gap, phase of silence after sound appearance, followed by reappearance. Secondary hypertension should be suspected if patient develop sudden onset hypertension with diastolic blood pressure over 105 mm mercury, persistent elevation of diastolic blood pressure after more than 100 mm mercury despite of treatment. Elderly patient develop accelerated hypertension. Therapy. Why? Therapy because there is greater benefits than in younger patients. Stroke reduced by 30%, cardiovascular events by 20%, dementia by 50%, mortality by 13%. Clinic blood pressure measurements. Aim for target clinic blood pressure below 140/90 diastolic mm mercury in people aged under 80 to 60 years. Aim for target clinic blood pressure below 150/90 mm mercury in people aged 80-60 years and over. Over 80, 150/90. Therapy, lifestyle modification. Elderly respond as younger patients. Salt restriction. Despite there is a new study that sodium chloride, but only one study, doesn't affect blood pressure, but forget about this. Salt restriction, moderate exercise, relaxation therapy, pharmacological therapy. Pharmacological therapy started when hypertension noted in multiple visits. Non-pharmacological therapy have not lowered blood pressure into desired range. Evidence of end organ damage. Therapy, drug of choice, calcium channel blockers. Second drug of choice, ARBs or ACE inhibitors, low dose thiazide diuretics. Drugs to be avoided: centrally acting drugs, as it causes drowsiness, depression, impair the cognitive function. Adrenergic antagonists, because it causes postural hypertension. Non-steroidal anti-inflammatory drugs exacerbate hypertension. Risk of therapy is increased with age. Hyponatremia, hypokalemia with diuretics, confusion, depression with drugs affecting CNS as beta blockers, postural hypertension, which may lead to fall and fracture. Cerebral hypoperfusion if blood pressure is acutely lowered. Increased glucose intolerance, creatinine and uric acid with suicide treatment. Practical points. Start with half standard dose. Increase dose gradually. So we start with half standard dose. Increase dose gradually over several weeks. Check blood pressure in both supine and standing position. Adjust dose according to standing position. Monitor renal function and electrolyte status. Adverse drug reaction are 2-3 times more common in elderly than in younger patients. Consider comorbid conditions, which most likely diabetes and metabolic syndrome. When to stop? Withdrawal of antihypertensive drugs should be done carefully if the original level of blood pressure was mild to moderate. Blood pressure of patient has been in good control for continuous period 12 months. Follow up for lifelong with or without medical treatment. Thank you.